Chief Health Information Officer of Clinical Services with United Healthcare. Rob Tennant, who's the Director of Health Information Technology Policy at MGMA. Another provider perspective we'll offer today is Dr. William Thorwarth, who is the CEO of the American College of Radiology. And we are fortunate to have Dr. John Fleming with us today, who is the Deputy Assistant Secretary of Health IT Reform from ONC. Fung Kwan Su, delighted to have her here today representing the employer perspective. She is the Director of Evaluate with the National Alliance of Healthcare Purchaser Coalition. And last but not least, we're really thrilled to have Sagren Moodley, who is the Senior VP of Clinical Data Services at United, but also the Chairman of the Da Vinci Steering Committee and the recently named co-chair of the DRLS Medicare Fee-for-Service Prior Authorization Pilot. So we've got a really wonderful group with us here today. For your information, you're all muted right now, but we want to hear your questions and we want to get through as many as possible, which is why I noted we might be going over by a few minutes today. If you have a question throughout the period today, please go ahead and submit those through the chat. Kaylee on our team here is standing by and keeping track of all of those questions that come in, and we'll get to as many as possible. And then finally, the slides and a recording of this presentation are going to be available for download on the eHi website later this afternoon in just a couple of hours. And I want to thank Athena Health. We are a small nonprofit, and we could not do this important work without the generous support of organizations like Athena Health. Prior authorization is an important issue for many of us, and we're really fortunate that Athena Health is supporting this webinar today. Couple of quick points about eHealth Initiative for those of you who aren't familiar. eHealth really is all about convening executives from across stakeholder groups, and this was a great opportunity to do that. Prior authorization is just one example of how we can bring all the key players together to focus on really critical issues that need to be dealt with and changed to transform healthcare. Next slide. And this is just a sampling of some of our members that we work with at the eHealth Initiative and the Foundation. We work at a pretty high level, and we are interested in all kinds of executives from all different groups: payers, providers, vendors, researchers, consultants, patient advocacy groups. We welcome you to our conversations. We encourage you to get involved, and we would love to hear from you. So if you're interested in being at the table, if you're interested in having a voice and changing and helping to transform healthcare, I strongly encourage you to get involved with us. We are making things happen and changing healthcare, so join us. And I want to remind everybody about the eHi DC Resource Center, which is located online. As a nonprofit, we produce hundreds of best practices, reports, surveys, interviews, perspectives, blogs, all available at the eHi Resource Center online. Recently released reports on cybersecurity, AI. You can find the prior authorization materials there as well, and I encourage you to get online and check those out. Okay, that's me. Next slide. Thank you. So I want to talk a little bit about the process that we went through for this collaborative. You know, we started talking about this collaborative about a year ago at the eHi Executive Summit, and we started talking about how prior authorization was an issue. It was a really sticky issue, and we started to think about it really as a technology issue, and we thought, what if we could automate the prior authorization process? You know, maybe we could change it. And that was kind of how the conversation started a little bit. And as we got deeper into the conversation and we started to focus on it, we realized this is much more than a technology issue. The process itself of prior authorization has a lot of different pieces of information flowing. There are transparency issues and a lot of little pieces there. So we realized we need to take a much broader approach to this collaborative. So we pulled together all of these groups. You go to the next slide. We recognize there are all of these different efforts going on in healthcare right now. You've got AMA, CAQH Core has a great initiative going on, SPA, Da Vinci, American College of Radiologists. All of these different groups are working on prior authorization initiatives, and we thought, is there something we can do to help coordinate these efforts and bring them together, along with the government efforts, which are going on as well. I think ONC and Dr. Fleming can speak to that as well, has a really important initiative around PA as well last year that took place. And we have the DRLS as well. So lots of important work. So we pulled all of those groups together. And this is a bit of the timeline of what it looked like. So this started really last year in February when we identified this as something we wanted to work on. We started researching the groups and then gathering the groups together to meet as a roundtable and as a collaborative. Really throughout the summer and the fall, September, November, we had a lot of meetings in person. We also did a lot by email and virtually, phone calls. We did a couple of webinars last year as well with United Healthcare to talk about some of the work that we were doing. And finally, we kept developing these considerations and coming up with these ideas for elements that we agreed upon. And it took us quite a while to come to agreement on them, but we finally did. And that's what we want to share with you today. So this is a list of some of the participants in the collaborative. I'm certain that I'm going to apologize in advance because I'm sure there's someone that we left off of here. But we had a lot of help and a lot of really sharp minds and passionate folks in the room who were at the table, willing to negotiate and engage and have the tough conversations about where we need to go with prior authorization. And I do want to just, again, thank them. You know, we couldn't have done this without you. And it's really tough to have these thoughts. You know, a lot of finger pointing goes on in prior authorization between providers, payers, vendors, you know, who's at fault. And this wasn't that at all. I think we had a great group who was really willing to come to the table and have thoughtful discussions about where transparency was needed and how we could improve this process. So what we're going to do now is I'm going to let John Zimmerman from Athena Health, and then we'll hear from Dr. Steve Waldron from AFP, talk a little bit about some of the pain points, which was the first part of the process that we went through in the collaborative. And then after we hear from John and Steve, we will go right into the considerations, and we'll have two of our group members as well walk through what we came up with there. And then we'll wrap up with a lot of important work that's going to come out of this and is going on right now in the industry. So John, why don't you go ahead and take it away?
You bet. Next slide, please, Claudia. So thank you, Jen, for your leadership and your recognition of the contributions of all of us to this challenge. I just want to take a minute and do three things very quickly. Number one, thank the courageous pioneers on this call and on this project who have put their collective energy behind this critically important problem that, quite frankly, needs to be solved. If you look at the top of the slide, I want to show you all some idea of how bad it really is and actually physically what it looks like. That thin band at the top of the slide is an actual journey map. A journey map is a careful step-by-step analysis of what actually happens in real life and in practice. This was modeled at a customer health system in practice that we're very familiar with. So we wanted to see, can we really capture all the steps and how bad it is? Well, as you can see, it is complicated, long, and fraught with expense and opportunity for error. As a matter of fact, there are 9 disparate data sources, 5 enterprise systems and various portals, and 29 steps, and that's just for the happy path if you get through it with no rework the first time. This is something that, as you can all see and we'll talk about, must be solved. And quite frankly, the pain is real. You see on the bottom of the slide the impacts on cost, patient care, and physician and staff frustration that needs to be addressed. I'm going to turn it over to Dr. Steve Waldron from the AAFP, who's going to share more with you about that. Steve, over to you.
Thanks, John. Appreciate it. And Claudia, if we can go to the next slide real quick. So I want to put a prior auth into context. So this is a survey that we did of our membership in 2018, and we're asked them to tell us what are the top 3 challenges that they're dealing with. And administrative burden is just all throughout this in regards to what are the top ones that they're dealing with. But if you look at the prior auth, which is a little bit farther down on the list, these are at least 10% of our members though that say this is one of the top 3 problems that they deal with in their practice. And you think about all the challenges they have with documentation and a lot of things you hear about EHR and all the regulatory challenges that they're dealing with, still 10% say that prior auth is one of the top 3. The next slide. So the AMA has done a significant amount of survey work in regards to prior auth, and I'd encourage you to check out their site. I just put in the chat, which is the AMA's prior auth site, and you can get more details into the survey data. But I wanted to highlight a couple of things, and John alluded to them. There's a physician impact, and then there's kind of the patient impact. So for the physician impact, this is something that the practice are dealing with significantly. It's requiring a lot of time and energy from the physician and the practice to be able to do these prior auths. And for a lot of our docs, it's frustrating when clinically they know it's the right thing to do, but they still have to go through the hoops to prove that they're clinically making the right decision. And a lot of times they also feel a lot of this burden is because they don't have the right information to make the right decision. So they're told after the fact that, nope, that's the wrong med, it's too expensive, or you have to do a prior auth. But if you would have picked this other drug, you wouldn't have to go through all this stuff. And we know clinically maybe that drug is fairly equivalent for that particular patient. So if we knew that up front, it would reduce the hassle for physicians, patients, and manage the cost we want to be able to do. The second graphic there is a slide asking those physicians in the AMA survey, well, are things getting better though, at least? And unfortunately, it's not. About half say that it's actually worsened in the last several years. There is a glimmer of hope for that blue bar toward the bottom is that they've seen some impact. And my hypothesis is that blue bar is due to the pilots that plans and government and other people are doing to address this particular issue. So there are some solutions out there, and the question then is how do we scale that up so that in the next 5 years, that blue bar is the most of those percentages. So on the next slide, let's talk a little bit about kind of the patient impact. So not only is it a hassle for physicians, but we're seeing that it's also decreasing the time that patients have to be able to get the therapies that they need. And we're also seeing that some of the care is just being deferred because they just don't want to go through the hassle, or by the time that you get the prior auth and get everything done, the patient is not filling their script. So this, again, the survey from physicians said that about 28% said that physicians think that they led to some serious adverse event for the patient. So not only are we not addressing the cost issue, we're not addressing the quality issue as well with some of these implementations of the prior auth. So I hope that gives you a sense that, it's just not a physician challenge with these prior auths, it's also a patient issue as well. So next slide. So I think that gives you a little bit of understanding of some of the burdens from a provider perspective and a patient perspective.
Thanks, Steve. That's really helpful. Now we're going to hear a little bit about what the group came up with. So we spent a lot of time discussing the pain points for all the different stakeholders. As Steve mentioned, it's not just for the providers, but the patients and the payers as well. So now we're going to hear from a payer and a practice expert, Rob Tennant and Dr. Anupam Goel, who are from United Healthcare, who are going to walk us through some of the recommendations or considerations that the group came up with. So Rob, I think you're going first.
Great, thanks, Jen. And I wanted to start off by thanking Jen, Claudia, and the eHealth team for pulling together a very diverse and motivated group of stakeholders. We've all heard the term herding cats is a challenge. Well, this was herding hungry cats, even more of a challenge. But the fact that this group came together very effectively and was able to come up with a consensus set of considerations, I think bodes well for the future for this very challenging transaction. So next slide, please. And MGMA's own surveys really dovetail with what John and Steve outlined it's a huge challenge. And so we wanted to talk about the 4 considerations. And the first one, arguably, perhaps the most important, the most opportunistic, and it centers around the word transparency. Really what clinicians want is all information that they need to make the right decision at the point of care, right when they're having the patient encounter. And so the first consideration really focuses around 2 concepts, around information related to benefits coverage and also evidence-based clinical guidelines being pushed directly to the clinician. Next slide, please. So what does this mean? What physicians want is to be able to understand the insurance eligibility of the patient, the benefits coverage, the payer documentation requirements, and preferably the patient financial responsibility, again, right when they're having the patient encounter. I think we all agree that having that information at our fingertips will allow us to make the right decisions for the patient. The other huge opportunity here is to have the clinician have the information related to clinical guidelines, again, at the point of care. Next slide, please. We're seeing an enormous growth in the adoption of EHRs. And again, this presents a unique opportunity. It allows the clinician to have the information related to, for example, advanced radiologic tests, all evidence-based, the guidelines pushed directly to the clinician, and this will allow for any identification of coverage gaps. And again, we're seeing some very aggressive work by a number of professional associations, in particular, American College of Radiology, American College of Cardiology, developing these evidence-based guidelines. We know about the CMS Appropriate Use Criteria program, which will go into effect in 2021. But really, it's a broader issue than just a government program. Really, what we're pushing here for is clinicians to get this information about the right tests, to have that at the time of the encounter. Then we believe they will make the right or appropriate decision, which will be good for the patient and also produce efficiencies in healthcare. Next slide, please. We've also seen a lot of movement in the area of pharmacy benefits. There are a number of products now on the market that allow clinicians at the time of service, when they're seeing the patient, allow them to understand if a drug that they've selected is in the formulary, what the patient out-of-pocket expenses will be, whether or not a prior auth is required. And most importantly, if they find out that a drug will be very expensive for the patient, these systems will prompt them with therapeutic alternatives. And that is a huge leap forward. That will allow the clinician to say, oh, I think this might be a better choice for you and might decrease costs. So we're seeing that. And as you'll hear a little bit later, there's also movement in that area in the medical services side. Again, by allowing that information flow to happen between the payer and provider, we have enormous opportunities for data interoperability and really decreasing the friction associated with prior auth and hopefully making the process more efficient. Next slide, please. So the second consideration is something very near and dear to the hearts of physicians, and that is there any opportunity to decrease the overall volume of prior authorizations? And we think there's some chance here. So if you go to the next slide. So obviously physicians would like to see prior authorization go away entirely, but we recognize that that's probably not going to be the case. But are there opportunities to decrease or eliminate prior authorization requirements in certain situations. So, for example, patients who are taking medication for chronic illnesses, who they need refills probably for the rest of their life. Do we really need to be doing a prior auth in those situations? Patients undergoing repeat procedures, medications and procedures with low denial rates. So if a payer is approving a particular medication or procedure 90–95%, do we really need to be going through the hassle? Also, the term gold carding is used, where a physician has proven themselves to be particularly adept at following the requirements of the payer. Those folks could be given the opportunity not to have to do a prior auth. And finally, we're starting to see more and more practices moving into risk-based contracts where they themselves are held responsible for healthcare costs. It really is counterproductive to then force those folks to engage in prior auth when they have skin in the game and they have every reason to keep their health costs low. So with that, I will turn it over to my colleague Anupam to talk about the final two considerations.
Thanks so much. So moving on to consideration number 3, we really think that all members of the healthcare industry should consider using existing industry-endorsed standards when possible and incorporate new standards as they come into being to improve the prior authorization process. We've listed a couple of sample existing standards today from the HL7 community, direct messaging, and then from our EDI folks. We think these new standards will add value to prior authorization as they come online. We think they have tremendous potential and look forward to having them as part of our armamentarium as we think about tools to optimize the prior authorization process. Next slide. So really, what does that mean in nuts to bolts? What we're thinking about is you've got to use existing standards today. And we have noticed that there are some standards that are not adopted widely amongst our payers and providers. And we'd like to see much more of that moving forward. If we can't agree on how to communicate, it'll be much harder for us any work around prior authorization now and in the future. We would encourage government work to augment existing standards when appropriate, and then consider developing new standards to help improve the process. And so there are several initiatives underway to help us think about how the federal government can help us encourage that path to the future. And then finally, I think from all of us, as we get new standards in place or as we augment existing standards, we need to have a process where we transparently share our roadmap with each other so we can all figure out ways to move forward in a new world. It's been interesting. We've talked a little bit about how to remove faxing from healthcare, and we struggle with how to bring the industry forward as a group. And we think that's just a really rudimentary step in prior authorization that could be addressed with technology today, but we haven't put in enough enforcement around existing standards or encourage people to stop existing fax processes to move us to that new space. Next slide. So the last consideration that we have on our recommendations or in our group of what we decided was that we should all explore alternative payment models that include bundled prior authorizations for multiple things around an episode of care or a disease. So rather than requiring different authorizations for procedures or medications or DME, can we do things that say, for this condition, we expect to have these 7 things together as a bundle to move that forward? Next slide. So we do think that this idea of bundling affects us in a way that it makes us feel like we're more engaged with our members and appreciate the care journey and can help us think about how to approve things all at once rather than asking for individual pieces. We think back to us, we'd have to do some more work around coordinating how payers and pharmacy benefit managers interact with each other. Some of us are co-owned, some of us have a partial ownership, but the reality is, I think institutionally there are firewalls within many organizations that prohibit good communication around how a member might need both medications and procedures to get treatment for the condition that they have. We think if that kind of combination or bundling occurs, it should reduce the burden on many of our ordering providers. Next slide.
Great. Thanks, Anupam. All right. Well, that's a little bit about what we came up with. We want to go into now, there's a lot of work going on around different initiatives. I know we've gotten some comments about initiatives that we didn't mention. I apologize in advance. There are many initiatives that we looked at, and truly an oversight if we didn't list your initiative on here. We recognize them and we will add them later. But we're going to go through right now. I think we're going to start with Dr. Fleming from ONC, who's going to talk a little bit about what's happening next in terms of the policy piece. Dr. Fleming?
Yes, thank you, Jen, and great to be on with everyone. First, let me give everyone just a thumbnail of what we do at ONC. We're primarily involved in EHR certifications. We're currently writing and developing rules and regulations to promote interoperability, also information blocking in order to stop information blocking, and of course, transparency is a necessary part of prior authorization. And then finally, clinician burden, area of my focus, and a number of studies have shown that 50% of clinicians' time is spent unproductively working on their computer on various and sundry things that must be done, including prior authorization. And if you think about it, if we can unleash just a portion of that 50% loss of productivity, how many more patients we can care for, and how we can lower cost of care. The four main areas of burden include documentation burden, prior authorization, quality measurement and reporting, and then prescription drug monitoring programs. So in talking about prior authorization, what we see is that the current focus today is that there are two armies on each side of the fence, an army for the payer, an army for the provider, and they battle over medications and referrals and DME and all sorts of things in order to see how we get care for a patient. And in many cases, this system, when it fails, actually saves money, at least at first glance. But in fact, what it does is it prevents patients from getting timely care, which could lead to further cost, morbidity, and mortality downrange. So really what we're trying to do here today is to work together in a collaborative way to see how we can automate the process of prior authorization. Where we come in from ONC is what can we do in order to facilitate transparency, because it may not be, in the view of every payer, a good thing to have transparency. But we think that it will be a good thing. It will ultimately save money, but it'll also save lives. So what will this look like in the future? I'm a family physician. I practiced in a small town for over 30 years. And I can picture in my mind a patient sitting next to me, viewing the computer screen with me. And as we select medications, DME, referrals, and testing, the patient views the screen with me. And we look at what is the out-of-pocket cost going to be. We look at what are the select tests, what tests are going to be improved, and perhaps what are the best tests in order or medications in order to achieve our goals. And when that patient leaves the exam room, the patient already has approval through the automated process for every medication, every treatment, every test. They have approval numbers, and they know exactly what their out-of-pocket expense will be. I know that sounds futuristic, but from a technical standpoint and a policy standpoint, I think that that's out in the very near future. And I think that what we will see is lower cost, certainly less hassle, and much higher compliance and much better outcomes in order to do that. So that should give you some idea of our work as we collaborate with our partners, both inside HHS, including and especially CMS, but also our outside partners as well. Thank you.
That's really helpful, Dr. Fleming. Thank you. Next, we're going to hear from Dr. Phoong Quan Su, who is the director of Evaluate, the National Alliance of Healthcare Purchaser Coalitions, and was really a great partner to us in terms of understanding the employer perspective. And I think she can also, we've had a number of questions about the involvement of other payers, and National Alliance has been great at getting communities involved with this work. So, Kwan?
Thank you so much to EHI and all the other panelists. Again, for the people on the line, in case you're not familiar with National Alliance, we have a membership of over 40 different business coalitions across the country whose members are employers. And what we hear from our members is that employers want their employees to get to the right care faster. Our coalitions do understand that, you know, some of this prior authorization is also based on employers wanting to control costs. I think you heard Jennifer up front saying that, you know, cost is a consideration. So it's really, our coalitions do a lot of work educating members about what is high value care rather than low cost care, which can be could lead to some of this prior auth issue. So I love what Dr. Fleming described. I think that's what our purchasers want. Their expectation from payers or their insurers or their TPAs is that they come up with a way, working with the provider community, the clinicians, in creating a system that Dr. Fleming described, where patients and their doctors can get to the right answer faster. And there's a couple of things, you know, in terms of the consideration. So the transparency of the policies, if there's a way to have a single portal to do all of this for the reduction of burden. But ultimately what they care about is the patient experience and the outcomes. And really, if PAs end up in them getting delayed care, as we talked about the pain points, and also if it ends up what we found in mental health delivery, if it ends up in providers not joining a commercial network because of the hassle factors, they don't want that. So whatever they can do and whatever you guys can do would be really helpful. We do have 4 coalitions across the country that have expressed interest in testing out some pilots that people, you know, that if they can get a couple of insurers to collaborate, whether it's around this bundling of PAs that Dr. Anupam Goel talked about, or the transparency, they'd be interested. One of the coalitions is actually doing a lot of work around oncology, and we know that there's a lot of PAs in that front. And then finally, I like the idea of also making sure that we have PBMs in the mix, because the medication PAs really are from them. Thank you.
Thank you so much. And I can't stress enough how important it was to have the employers involved in this initiative. So we thank you. Next, we're going to hear from Dr. William Thorworth, who's the CEO of the American College of Radiology, doing some really exciting things that we learned about. So Dr. Thorworth?
Thank you very much, Jen. And again, my thanks for the opportunity to participate in this process. And we'll again repeat how collaborative the atmosphere was with so many different stakeholders around the table. This is very kind of near and dear to the heart of the American College of Radiology and the radiology community in general, because we think that it's critically important that prior authorization for, in our case, diagnostic imaging procedures or minimally invasive procedures be handled efficiently and decrease the burden on the referring physician population. I think the key consensus of the group was that the goal here is optimization of care. It's not restriction or limitation of care. And I think that's really the goal that all of us realize will produce the highest value care in the end. I think that particularly from the clinical standpoint, and this is not from coverage standpoint or a person or patient's insurance program or benefits, but from a clinical standpoint, it's got to be rooted in evidence-based guidelines. And we've been developing appropriate use criteria within the ACR since 1993 in order to try to guide providers, and this is before any of the cost containment pressures were on, guide providers to the appropriate test for a given clinical circumstance. I think also we have to say that it's got to be seamless for the referring provider. The point of care delivery has been described by many in the earlier parts of the discussion this evening, has got to minimize the burden on those healthcare professionals. Because if they're spending, as has been cited, more than 50% of their time, I think Steve mentioned earlier, with their face in front of the computer, then they're really not able to attend to the patient as they would prefer to do. I think it's also going to be best accepted by the healthcare professional community if it's educational for them. And so if at the point of care, they can get guidance as to what in our case, the best imaging procedure might be, or the best pharmacy recommendation might be, it acts as an educational process, and I think will really be much better received. So just to give a background in diagnostic imaging, this is already happening in over 2,500 facilities around the country, and will be expanded January 1st, 2020, with the implementation of the PAMA mandated consultation of appropriate use criteria when healthcare professionals request advanced diagnostic imaging services. And by that I mean CT scanning, MRI scans, nuclear medicine procedures, including PET scanning. And that's for Medicare patients. So the studies already demonstrate the increased appropriateness of use of those procedures when appropriate use criteria is provided through clinical decision support at the point of care. Those studies are already out there. It reduces patient risk of unnecessary exams, radiation and contrast exposure, and wasted cost and inconvenience. And also, work is also underway for very similar applications in lab and pharmacy. So to go back to Dr. Fleming's comment earlier, I can tell you this is already being used by providers in those communities that I just cited, where a patient will be with the physician. They'll say, I have a strained pain in my low back. I cleaned out my garage last weekend, and I want an MRI scan. And the physician can, with good evidence behind him, turn the screen and show that patient that they don't need an MRI of their lumbar spine. That rather, the best thing might be physical therapy and conservative management first. But I do think that this is again, getting back to what I said in the beginning, I think optimizing care and not looking at prior authorization as a restriction of care is really where we want to go. I think that there's clinical guidance, whether it be put out by the National Coalition on Cancer Care, whether it be by other specialty societies, including the American College of Cardiology. We can provide the clinical guidance that will create that atmosphere and environment of optimal care without the undue burden that was described in the 29 steps that John talked about at the beginning of the session tonight. So again, I look forward to your questions and would be happy to discuss any of these, but let me turn it back to Jen.
Great, thank you so much. And we've got a lot of questions coming in. We are got them all here and we'll get to them shortly. I do want to quickly, before I introduce Sagrin, a big call out to United Healthcare, Sagrin and Anupam for being so supportive. We had a lot of involvement as well from AHIP, Highmark, and other payers in this initiative. And these payers really did a great job. I mean, they jumped in with both feet. They were full participants, really willing to look at this process. And were tremendous contributors to this. So I just want to thank you, Sagrin, before I introduce you. And the other thing about Sagrin we're really fortunate to have on the line today is Sagrin chairs the Da Vinci Steering Committee, which is doing a lot of important work here related to prior auth that overlaps with this. So we did work with the Da Vinci group as well as part of this. So Sagrin, why don't you tell everybody a little bit about the Da Vinci project?
Thank you. First of all, good afternoon. Can you guys hear me okay?
Yep.
Okay, great. So I'm just overwhelmed with the participation, the interest and hopefully participation from such a diverse group to really advance the healthcare delivery system speaks volumes. Speaks volumes specifically as it relates to prior authorization, the pain, and more importantly, the urge to solve it. And really tremendous gratitude to eHealth for their inaptability to be able to convene such a diverse group of stakeholders. This really does take a village to solve for. I'm going to give you, I have a few minutes here, so I'll give you a quick update on DaVinci. If you haven't heard of it, there'll be some reference links in the material that will be distributed for you to be able to find the breadcrumbs and where to go on the eHealth7.org site and get more information. But why don't we move forward up to the next slide. So really, in a nutshell, if you think about value creation is really changing the narrative and ultimately the relationships between payers and providers. I cannot say this enough. These relationships are becoming, you know, change in a way that as we sit down and think about it, it's really not about denying access to care, but really about driving clinical decisioning at the point of care. Our ultimate goal is really to, as we think about triple aim and think about improving health outcomes, reducing the administrative burden, improving overall per capita cost, but more importantly, patient satisfaction as we think about driving costs. I cannot stress enough. So as we thought about the shift to value-based care and those value creation models, whether it's global capitation or pay for performance or anything else, even value-based care, we needed to solve for use cases that were relevant for value-based care. And as we thought about it, and I'll get to the use cases in a second, we knew that we needed a very rich, diverse, multi-stakeholder group. This included HIT vendors, EMR vendors, providers, and payers. We knew that anything we needed to do or wanted to do had to be anchored around standards. And that really was our key to the success. And most importantly, we needed to be very practical, that it solved real world problems, and that as we developed and built the reference guides and implementation guides and the architecture, it had to be open source, open for the public good, provided into a public domain so that anyone could pick it up and really deploy it. So we go to the next slide. This is just value-based care. So as DaVinci started to merge and form, we started to think about how do we really solve this problem around promoting or accelerating fire for value-based care. If you jump to the next slide. With that said, a number of organizations, over 27, 12 payers, 12 HIT vendors, 3 EMR vendors, plus providers really got together, formed an initiative. And if you go to the next slide, as we sat down, we started to think of maybe advance the next two. These are snapshot of the participants. Go forward one more. And one more. As we thought about the use case development starting in 2018, it anchored around these initially 9, now extended to 12, and you'll see the last few. This is very relevant to prior authorization, because if you think about prior authorization, it really is a means to an end. Ultimately, it should support a treatment plan or a goal. And if it's part of the treatment plan, and if you can overcome the benefit check I'm talking about this from a payer lens, is it a covered benefit? Is it medically necessary? Is it appropriate? Once you overcome those two, the very next thing you want to try to promote so we can keep the per capita cost down of healthcare is it being delivered in the most optimized site of care? Is it an elective, an ambulatory surgical center versus an inpatient setting? And hence, the net value of that is lower out of cost for the patient or consumer. And so when you think about the DaVinci use cases, I won't drain this, but there's information on the website for this. But in 2018, there were 4 primary use cases: document exchange for quality measures. In fact, coverage requirements discovery and documentation template rules are 2 key use cases for prior authorization. Coverage requirements is really the frustrating question that providers will always have: is a prior auth required? for this procedure for this patient. And even just overcoming that simple question is a mission in itself. And so CRD attempts to solve this question, if you will. So if you imagine a world where there's a travelocity of prior auth, it's back one slide, if you don't mind. You could imagine that this question could be asked: is it a PA required, yes or no? And then if it is required, to the next use case, the documentation template rules out for this particular procedure for this PA. And then everything else is supportive of that. If there's a need to exchange clinical data in support of authorization, it's supported. If there's a need for payers to exchange data back into the provider, that's supported with payer data exchange. And in fact, if you look at the proposed rule that's just come out by CMS, there's a payer-to-payer exchange. And if you think about cross plans, to move forward all the clinical data and evidence to ensure that a patient who has a chronic condition has, certain services covered, that those can continue to be covered without any disruption and any delay in care that could be critical for the patient. And of course, authorization support will build out. So a lot here, but I'll move. And last thing I want to say here is the idea of Da Vinci is to create implementation guides, reference implementations, as well as pilot the solution and deploy it, creating this blueprint, if you will. So let's move forward to the next slide. When you have the tools and the reference guides and application guides, you really have the building blocks to be able to connect these endpoints and really drive through interoperability. Forward, please. One more. So I'll talk last slide, one back. So CMS is piloting an initiative called Documentation Requirement Lookup Service, and it's really leveraging the two use cases of Da Vinci: CRD, Coverage Requirements Discovery, and template. It's attempting to apply, if you look at the bullet, just second to last, allows providers to discover prior authorization and documentation requirements at the time of service in their EHR or integrated into a practice management system. And when I talked about clinical decision and point of care, the nirvana for us is that a provider doesn't have to leave their workflow, and they could then really get the approval for a procedure or service. Even better, if we're in the EMR, we could go down in the patient chart and auto attest or auto fulfill certain things. Example, A1C measures for an insulin pump. And so this is very exciting. We welcome you to participate. There's tons of information on the following page. We want to move to it, of how you can participate and get involved with this initiative as well. Last slide, if you don't mind. In fact, I want to talk about this. So at HIMSS 19, a couple of weeks ago, we had an interoperability showcase and actually showed this at work. There was this real code at work where we had Dara, the patient, moving across different care settings. She goes from a primary care to a cardiologist with a COPD condition, shortness of breath. She gets admitted to a hospital for an angioplasty, has to get discharged with an oxygen dependency. And we actually use CRD to ping the payer for coverage requirements, discovery, and documentation rules for oxygen. She gets discharged for an oxygen and goes to an outpatient setting. We do a 30-day MedRec, also using one of the implementation guides out of Da Vinci for 30-day MedRec. So this is real. It's really a testament to the great work by just so many organizations who have come together in a way, in a very collaborative way, to solve for this. Last slide. So here's a way for you to get involved. Here's a way for you to find information on Da Vinci is convened under HL7. It's a private sector-led initiative, but it is convened under HL7. So you could go to HL7's website for Da Vinci, and then on DRLS, you can go to the CMS site as well. Thank you, and back to you, Jen.
Thank you so much, Sagrin. And this is a really critical initiative that's going on here, and we strongly support this and this work moving forward. So I wanted to make sure we had time to talk about that. A lot of this work flows into that. We've got some time for some questions now. We have a lot of questions, so we'll get through as many as we can. The first question is actually for the providers, and Bill, I guess I'll start with you from the American College of Radiology, and then Steve, maybe you can take the second part of this from AAFP. But there's a question about, what do you do, Dr. Thorwarth? There's only peer-reviewed evidence or literature for about 40% of clinical scenarios for imaging and radiology. So how do you handle prior authorization in those situations? How do you incorporate this into the EHR? How does that work?
Yeah, again, I can speak from our experience. We right now have 189 clinical indications with about 1,200 scenarios. So there might be, a half a dozen on prostate cancer, for instance. I think we need to continue to expand that work, and within the college, we actually have a so-called Gaps in Harmonization Committee. Part of that exists because of use of synonyms for different things. We heard a report the other day of a perceived gap because a patient wanted to get clearance for a testicular ultrasound for scrotal pain, but they wanted it for acute scrotal pain as opposed to scrotal pain. So a lot of it has to do with working through the mechanism, the so-called clinical decision support mechanism. But as we continue to build out these indications, I think there's going to be ever progressive, smaller number of indications that don't have guidance. Steve?
Yeah, and the thing I would add too is in addition to kind of the level of guidance is the harmonization of the kind of rules across multiple different payers or different individual plans. So I think there's part just to make sure that there's transparency and harmonization such that there's a common set of rules, and we use the best level of evidence that we had and maybe that at the particular time is expert opinion. But I think that's the other challenge there is just kind of harmonizing in addition to identifying the appropriate level of evidence.
Great, thanks. So John Zimmerman from Athena Health, can you talk a little bit about standardization in healthcare? We have a question from someone who wants to know how far can standardization go in healthcare? Could all EHRs use the same software to process prior authorizations? Would that streamline things, and is that even possible?
Hey, thanks, Jen, and that's a really great question. I think it's important for me to maybe just follow on with what the two great doctors just talked about. If it can be if this knowledge base can be harmonized into a set of clinical rules that would support CDS processing and made available through standard calls, not at all unlike what Sagrin showed, then I think the answer is absolutely it can, which is one of the great things that came out of these recommendations in this project. I believe personally this is very doable, but only with the right level of collaboration and coordination across these stakeholders. But from a technology and an EHR or EMR perspective, oh yes, this is well within the realm of doability, but it's going to take continued collaboration and coordination to really bring it to life. And with the support of ONC and Dr. Fleming behind us, we could be onto a really important path to really make a difference here. So definitely within the realm of possibility. Thanks, Jen.
Thank you. And this question for Anupam and Sagrin. Can you guys talk a little bit about the role of AI possibly in automating prior authorizations? Is this a realistic thought for the future?
Yeah, it's the next question you automatically ask. So when you get and you quickly ask questions about site of care and site of service, and if you say yes, you quickly ask questions about, well, can I get it? What is the cost? Because it's not just good enough to say an authorization is covered or a service is authorized. You want to know what it's going to pay, because that may alter your decision about what you do and where you get your care. But then when you think about cancer journeys and oncology service based on evidence-based guidelines, we know that certain things would happen as a result of certain diagnoses or conditions. For example, knee replacements and arthroplasty is going to require imaging and surgery and DME and possibly definitely physical therapy. And so with AI and machine learning, we're looking for what we call gold carding opportunities at the provider level, the procedure level, or the patient level. And then not to have to ask why you're getting the service, but prompt you to get the service to drive better outcomes and proactive wellness.
Great. Anupam, one question as a follow-up to that. One of the participants today would like to know, could professional organizations like the AMA and other professional organizations help support payers in some of these areas where there's the greatest variation in utilization and intervention? You know, how could professional organizations work with payers?
Thanks, Jen. No, I think there's a lot of opportunities for groups like the AMA to work with payers to help make this a cleaner process. I think all of us are expressing frustration. And I think we're going to come up with solutions that'll have a little bit of pain for everyone. I think that's what good governance is about, is thinking about ways to help allow providers to do their job while acknowledging the payer's primary imperative to help control inappropriate testing in ways that make sense both for members and for providers. And so I think that conversation, it's not one wins, one loses. I think it's going to be trying to think about innovative ways to come up with solutions that meet everyone's needs.
Yeah, and if I could just add, you know, one of the things, payers a lot of data based on admin claims data. And so, you know, we obviously, it's an obvious question. Why are you asking for information that you can otherwise derive from historical claims for this patient if assuming they were covered by you for the last few years? And so that's also lending itself to certain opportunities of, we know enough about a problem or conditions or treatment plans and goals that a patient has. And so, you know, I think that's the opportunity as well.
Dr. Fleming, we actually have a question here about state legislation. There's been a lot of state level legislation, I guess, in 12 different states now. Do you see that continuing, or do you see the federal government stepping in and doing something at a different level?
The two areas that I see state legislation has to do with the prescription drug monitoring programs, and there's a lot of conflict between them. We also see problems with privacy laws that vary from one state to another. And then, of course, when it comes to HIEs and interoperability. So I do think that the federal government will play a larger role. We try not to be prescriptive, but try to build consensus in everything we do, because we know that things that are overly regulated will stifle innovation, and that's the last thing in the world we want to do. So we look for where we can build consensus. I think our TEFCA product that's coming out, where the trusted exchange is so important, where again we're building consensus among providers across the continuum of care. And we're taking care not to isolate and freeze in place certain technologies. We want technologies such as FHIR and others to continue to evolve going forward.
Great, thank you, that's helpful. Rob Tennant from MGMA. Some doctors might think, you know, you're calling this reducing burden, but I think you're reducing my autonomy because sometimes prior authorization fights are about difficult decisions where the rules aren't quite so clear. Can you speak a little bit to that, Rob?
Yeah, no, it's a good question. Obviously, physicians do not like to have their professional judgment questioned, but they also want good information. And I think what we're seeing is the movement of data, not just clinical data, but administrative data, because as you saw from the statistics, the rate of burnout, the frustration level is extremely high with prior auth. So I think we would be willing to give something up if we were able to get very near real-time adjudication of prior auth requests. And if we got, again, the clinical guidelines pushed to us in real time, what we don't want is to have to go outside our workflow, especially if not all payers are going to play in this space, and we're forced to leave the EHR and go into a web portal. I think that would be counterproductive. But I think overall, there's great promise, and physicians are directly behind us.
Jen, this is Bill. If I could chime in on the answer to that question. In the PAMA legislation and in the CMS implementation of that for 2020, there's not a hard stop, at least as far as the diagnostic imaging, advanced diagnostic imaging services. So if a physician or other provider feels they need to go ahead with a test that may be outside the recommendations, it is in at least the imaging world, that's not going to be a hard stop.
Great, and we have a lot of questions about, were there patient groups involved? Were there other hospitals involved, other payers involved? Yes, is the answer to all of those questions. We just weren't able to invite everybody on today, but lots of those groups, and we're happy to give you more specifics on that after today. We really have only time for maybe one or two more questions. There is actually kind of an interesting question here about, are there other countries or companies that are doing this better than we're doing it today that we can learn from? And I don't know the answer to that, or who might take that question. Do any of you know? Other countries?
This is Bill. I can tell you that the European Society of Radiology has adopted and adapted the ACR's appropriateness criteria and is starting implementation of what they call ESR iGuide in order to try to do appropriate use criteria application within the Eurozone.
It's Rob Tennant. I'll just talk a little about Canada. You'll find that in single payer systems that are funded by the government, they have every incentive to try to keep costs low. So they, in fact, it's very challenging to get, for example, advanced diagnostic images done. But the difference in Canada is that the rules of the road are completely transparent. So physicians know exactly when something is appropriate or not appropriate, and they know what clinical documentation is required in order to get approval.
Great. Any other comments on that? Okay. Great. Well, as promised, we've gone over by 5 minutes, and I know a number of our speakers have hard stops, so I want to thank them all for hanging in there for 5 extra minutes with us. And I want to thank again everybody for joining us today. Thank Athena Health for their support today. This is such a critical issue, and you haven't heard the last from us on this or these organizations on the phone with us today. And I think we learned a lot in this process, and we're eager to continue moving forward on this. This is just one step in the journey. So thank you everyone for joining us today. Have a wonderful afternoon.